Welcome to the University of Kentucky's Department of Anesthesiology YouTube channel. We're covering high-yield keywords on the topics respiratory anatomy, physiology, and thoracic anesthesia. This is videocast number 2 of a 5-part series. And as a reminder, the American Board of Anesthesia each year publishes keywords. From 2019, they are represented here. Approximately 10% of all the in-training exam keywords are on respiratory topics, and those that are in a purple color on the slides in part 1 through 5 of these videocasts represent those from 2019. Let's move right into the next keyword, which is airway resistance. Poiseuille's law. Poiseuille's law applies to laminar flow in unbranched tubes. So as air is going down the trachea, for example, is it laminar or turbulent? If it's laminar, Poiseuille's law applies to it. And that says that resistance on the far right at the top is proportional to length of a tube and radius of that tube, as well as the viscosity. Now, resistance is increased the longer a tube is, and the more viscous the flow of that gas going down through the tube, and radius has a huge factor on resistance. And in fact, if you decrease the radius in half, the resistance will increase by 16 times because it's related to resistance by radius to the fourth. But the least resistance in the total airway is actually way down there in the small airways because the overall area for flow is greatest. And the graphic on the bottom right shows resistance versus the location in the airway, trachea, bronchus, bronchioles, and the terminal bronchos. You can see way down in the terminal bronchos is where the least total resistance of the airway is present. Poiseuille's law is the relationship of length and viscosity and radius to resistance. Turbulent flow and gas density was a key word in 2019. Let's first look at laminar versus turbulent flow on the far right. You can see laminar flow where flow along the sides of a tube is slower than the flow velocity in the center of that tube. Turbulent flow, you can see the air movement in multiple different directions. There is turbulence occurring, and it can occur based upon many reasons. And Reynolds number is one of the ways to predict whether turbulence will occur. Reynolds number is a dimensionless number equal to density times velocity times diameter over viscosity. And the higher that number, the higher the chance that there's going to be turbulence. So factors that increase the chance of laminar flow becoming turbulent are things like if the gas flow rate is very high velocity, if there's lots of branches in the airway, and if the gas is very dense. Heliox is 70% helium and 30% oxygen. Helium is less dense than air. Interestingly, it has about the same viscosity. Since it's less dense, it actually lowers the Reynolds number and less chance there is for turbulent flow. And so if someone, for example, had tracheal stenosis or severe asthma and you mixed in heliox, there would be less resistance to flow through an orifice. If the flow was already turbulent, maybe you'd convert some of that back to laminar flow, and there'd be less resistance for air to pass through that tracheal stenosis or through constricted airways, and better exchange of gas. Our next keyword is oxygenation equations. The first equation is alveolar gas equation, which is used to calculate P big AO2, which is the partial pressure of oxygen inside the alveolus itself. P big AO2 is equal to the FiO2, room air being 21%, times atmospheric pressure at sea level, 760 millimeters of mercury, minus water vapor pressure, which at body temperature of 37 degrees is 47, minus PaCO2 over respiratory quotient. So this equation is used to calculate P big AO2, or the oxygen in the alveolus itself. Now, respiratory quotient, or RQ or R, is the ratio of carbon dioxide produced to the amount of oxygen consumed. And if you are producing 1 molecule of CO2 for every molecule of oxygen you consumed, that would be an R value of 1, or RQ of 1. And carbohydrates, if you're using that as your total nutrition, you would have an R value of 1. Proteins, it's 0.8, lipids, it's 0.7, and the average RQ is 0.8. One of the applications of RQ is in the intensive care unit. If someone is being fed mainly with carbohydrates, they're going to produce more carbon dioxide than they would be if lipids made up a portion of their caloric intake. If you replace some of that carbohydrate nutrition with lipids, you'll make less CO2, and then there's less CO2 that has to be exhaled, and weaning from mechanical ventilation may become easier by simply changing nutrition. At altitude, FiO2 remains 21%, whether you're at sea level or at Denver or at the top of Mount Everest, but overall atmospheric pressure decreases as you go up in altitude. This decreases P big AO2, or the amount of oxygen in the alveolus, which is going to then decrease the amount that's in arterial blood. Another take-home point from this equation is that if PaCO2 goes up, it can actually decrease the amount of oxygen in the alveolus. An example of this would be a patient in the recovery room who is awakening from general anesthesia and has been given opioids and is hypoventilating. And if they're given supplemental oxygen, as the CO2 builds up in their alveolus, the supplemental oxygen masks the fact that their CO2 is building up. Their saturation stays at 98% or so, while if they were breathing room air, FiO2 21, and their CO2, let's say, built up to 100, you could see how that would impact their P big AO2, decrease their P little AO2, decrease their saturation, and you would say, aha, why is their saturation decreasing? And it's because carbon dioxide is building up and displacing the oxygen from the alveolus. But supplemental oxygen can mask that hypoventilation. The next equation is A, big A, minus little a, oxygen gradient. This is used to monitor shunt. Normal anatomic shunt is about 3 to 5%. It's a measure of oxygenation efficiency, and we calculate the big A by using the alveolar gas equation above. We calculate the little a, actually measure the little a from an arterial blood gas, and if someone is on room air, this AA gradient should be less than about 20 millimeters of mercury. The next key word is oxygenation delivery and oxygenation use. Let's look at the graphic at the top and follow it around, starting with the lungs and oxygenated blood leaving the left side of the heart, where as it leaves the left side of the heart oxygenated, the PaO2 is about 100 and the saturation is about 98%. The hemoglobin we'll assume is about 15 normal. And a cardiac output's about 5 liters, and oxygenated blood is being pumped to the tissues. Arterial oxygen content is a combination of oxygen bound to hemoglobin and oxygen dissolved in the plasma. Most of it comes from that bound to hemoglobin. And C little AO2 is approximately about 20 mils of oxygen for each 100 mils of blood, or 20 volume percent. So 20 mils of oxygen is carried in every about 100 mils of blood. So the delivery of oxygen to the tissue, if you assume a cardiac output of 5 liters, a content of about 20 mils of oxygen for each 100 mils, times it by 10 to get it to liters, you would then have 5 times 20, or 100, times 10, or about 1,000 mils of oxygen being delivered, DO2, cardiac output times the content, to the tissues. And at the tissues, we use oxygen, basal metabolic rate. 1 metabolic equivalent is equal to 250 mils of oxygen per each minute. That's 1 met. 4 metabolic equivalents is approximately equal to what it takes to climb 2 flights of stairs. And when you ask someone preoperatively, can you climb 2 flights of stairs, you're kind of asking them, can you increase your oxygen use about 4 times from basal metabolic rate up to 4 mets? So as the blood leaves the tissues after removing about 250 mils of oxygen each minute from basal metabolic rate, the content of venous blood then is is decreased. And the content is actually about 15 volume percent, or 15 mils of oxygen for each 100 mils of blood, which was 75% of what it was in the arterial blood. And blood comes back to the pulmonary artery deoxygenated, mixed venous, SVO2 about 75%, and a P partial pressure of oxygen of about 40 millimeters of mercury. We will spend some time talking about mixed venous oxygen in the cardiac section of keyword review. So let's go down now to the two major topics. Oxygen delivery is equal to cardiac output, the 5 liters, times the content, with content being mainly made up of oxygen saturation, hemoglobin, and the standard number of about 1.36 mils of oxygen per each gram of hemoglobin. That's what's bound to hemoglobin, and then what's dissolved is P to LaO2 times 0.003. Oxygen use at the tissue level is cardiac output times the difference of the amount of oxygen delivered to it minus the amount of oxygen in the blood that leaves the tissue. So that's content in the arterial blood minus content in the venous blood equals VO2. So if someone has a basal metabolic rate of 1 MET, 250 mils of oxygen a minute, but their temperature goes up or they start shivering, you could see how their oxygen use would go up dramatically, and then you'd have to deliver more, either usually by increasing cardiac output. The next keyword is oxygen dissociation curve and some of the factors affecting it. On the y-axis of the oxygen dissociation curve is oxyhemoglobin saturation percent, and on the x-axis is partial pressure of oxygen in millimeters of mercury. And the P50, or the partial pressure of oxygen at which a hemoglobin is saturated 50%, is about 27 normally. Now, things that can shift this curve to the left include things like being cold, hypothermic, low 2,3 DPG. An example of that would be old, outdated transfused blood, doesn't have much 2,3 DPG in it, and acidosis, that is decreased hydrogen ion, and alkalosis, and carbon monoxide can shift to the left. So anything that shifts it to the left is going to make hemoglobin hold on to oxygen and not deliver it to the tissues as well. So hypothermia, decreased 2,3 DPG, alkalosis, and carbon monoxide shift to the left. As opposed to a right shift, which is reduced affinity of hemoglobin for oxygen and better delivery of oxygen to the tissues, is hyperthermia, temperature going up, increased 2,3 DPG, something that happens when you go up to high altitude, and increased hydrogen ion concentration, or acidosis. So a working muscle creates acid and the temperature goes up, all things to increase oxygen delivery or release of oxygen from hemoglobin. So tissue pH, the release of oxygen at the tissues, is favored by acidosis because it shifts the curve to the right. The P50, although it's normally 27, there are some things that can change that. Carbon monoxide shifts it to the left. Fetal hemoglobin tends to be lower than maternal hemoglobin because it wants to grab onto oxygen from the mother. And sickle cell actually shifts it to the right from that normal 27 to a higher number. Hypoxia physiologic effects is the next key word. A saturation of 90% is about a PaO2 of 60 millimeters of mercury, assuming a normal oxyhemoglobin dissociation curve, and the P50 is about 27 millimeters of mercury. In the lungs, if you have hypoxia to a single alveolar unit, the blood going past it constricts. That's pulmonary vasoconstriction from hypoxic pulmonary vasoconstriction. And if there's global decrease in oxygen to the lung, both lungs, pulmonary artery pressure can go up fairly dramatically. So hypoxia can increase pulmonary vascular resistance. In the brain, hypoxia stimulates hyperventilation. Your brain says, I'm not getting enough oxygen, and starts to stimulate you to breathe more, to bring in more oxygen. Cerebral blood flow increases when the PaO2 is less than 50. In general, oxygen has little effect on cerebral blood flow between a wide range, but when it gets below 50, your brain says, I can't take it anymore, I need oxygen, and you will vasodilate the blood vessels in the brain. Blood flow goes up even if you're hyperventilating that patient. And the example is a traumatic brain injured patient who you're trying to control their ICP by hyperventilation, but if they're concomitantly hypoxic, let's say from chest trauma, you're going to have a really hard time controlling their ICP because hypoxia increases cerebral blood flow and can increase intracranial pressure in that situation. Now, what about the cardiovascular system response to hypoxia? When someone's getting hypoxia and the saturation is going down in an adult, their heart rate goes up. Oftentimes they get hypertensive. Their cardiac output goes up as norepinephrine release occurs from the stress of being hypoxic. But the direct local effects of hypoxia is inhibitory on the heart and causes vasodilation of blood vessels. And at profound hypoxia, the blood pressure goes down, the cardiac output goes down, and the patient becomes bradycardic. So in the example of a difficult airway where you're having problems oxygenating a patient, initially they can often be tachycardic and hypertensive, and then as they get very hypoxic, they will become bradycardic and hypotensive. Note that adults respond to hypoxia in this characteristic manner of increased heart rate, but infants respond to hypoxia initially with bradycardia. So if you're taking care of a kid and they become bradycardic, make the assumption that the cause is hypoxia until proven otherwise. The next key word is CO2 transport or CO2 dissociation. How is CO2 carried about the body? It is mainly hydrated to form carbonic acid and then bicarbonate, catalyzed by carbonic anhydrase. So most CO2 is moving around in the blood in the form of bicarbonate, and that is shown in the graphic on the far right. Chemically modified, about 60%. There's the bicarbonate and the chloride shift going on. Protein bound to hemoglobin, about 30% or so, and then about 10% or so dissolved in solution. The Haldane effect and Bohr effect talks about oxygen and CO2 and the effects of each on the dissociation from hemoglobin. So let's look at the Haldane effect first. This is basically what's going on at the tissues when you have hemoglobin come into the tissues and releases its oxygen. When it releases its oxygen to the tissues, it facilitates the carbon dioxide binding to it, which makes sense. That's what you want to happen at the tissues, is to get the oxygen to them and then pick up carbon dioxide and take it back. That's called the Haldane effect. The Bohr effect we talk about in the lung, and that's where when the hemoglobin comes back to the lung with carbon dioxide bound to it and releases it from the hemoglobin, then it's ready and even better able to pick up oxygen. So the release of carbon dioxide facilitates oxygen binding. That's the Bohr effect occurring at the lung. Acute hypercarbia is the next key word and the effects of hypercarbia. By definition, hypercarbia is a P-Lillet CO2 greater than 45 millimeters of mercury. It can be secondary to inadequate ventilation or increased production. Inadequate ventilation would be example, so you leave someone partially paralyzed and they're not breathing with a normal minute ventilation. They could be rebreathing because of something wrong with your circuit, like an inspiratory or expiratory valve or an exhausted CO2 absorber, or CNS depression from medications like opioids. That would be inadequate ventilation. Increased production. You have a laparoscope, let's say, in the abdomen, insufflating carbon dioxide and you're absorbing it. A scope in the leg when a saphenous vein graft is being taken for coronary artery bypass graft surgery is another example of where CO2 insufflation can cause acute hypercarbia. In the ICU, if you have a lot of your nutrition coming from carbohydrates, remember that the RQ of carbohydrates is 1. You produce a molecule of CO2 for every oxygen used. If you replaced that carbohydrate with lipids, you would produce less CO2 for each oxygen used. And that is part of the reason you can change nutrition to more lipids, replace the carbohydrate with some of the lipids, and you'll have an easier time potentially weaning someone from mechanical ventilation. If you give a blast of bicarbonate, a couple amps of bicarbonate, watch what happens to your end-tidal CO2, it rises. And then when a tourniquet is released, when tissue has been hypoxic, metabolizing, producing carbon dioxide, and then you release the tourniquet and it comes back during an orthopedic procedure, for example, the CO2 will rise temporarily. The perioperative signs of acute hypercarbia Our vasodilation, a flush skin, extra beats of the heart, ventricular premature beats, often tachycardia and hypertension, a patient who isn't thinking clearly in the recovery room with depressed mentation and has flushed skin and is hypertensive, tachycardic, and sweating. That would be the classic signs of hypercarbia. And if you remember from the alveolar gas equation, if they're receiving supplemental oxygen, their saturation can be merrily going along in the high 90s, despite the fact that their CO2 may be up in the 60, 70, 80, or even higher range, and you draw blood gas and realize they are acutely hypercarbic, which is the cause for their catecholamine release, as well as their depressed mentation. You reverse, for example, an opioid, and suddenly they're breathing normally and their CO2 comes down. The next key word is organ effects of hypercarbia. On the brain, blood flow goes up when CO2 is high. If you have really high CO2, it can act like a narcotic almost on the brain. No change in MAC with elevation in CO2 unless it's really, really high in general. Cardiovascularly wise, when the CO2 goes up, it activates the sympathetic nervous system. That's the usual effect that we see from hypercarbia, that is tachycardic and hypertension. But CO2 is a direct depressant of the cardiovascular system, and so as it gets really, really high, you can get depression of cardiac output, blood pressure, and heart rate. Respiratory system, if the CO2 is up, the normal response would be to increase minute ventilation. And then if it gets really high, over 100 for example, you can start having depressed respirations just from that hypercarbia. Hypercarbia increases pulmonary vascular resistance. The right heart doesn't like that. Remember, chronic and acute hypoxia can also increase pulmonary vascular resistance. And also CO2 elevations right shift the oxyhemoglobin dissociation curve. So the usual response in the respiratory system is to increase minute ventilation. There's a constriction of the pulmonary artery and a right shift of the oxyhemoglobin dissociation curve. Metabolically wise, hypercarbia increases the stress response of the body and norepinephrine goes up. pH goes down, and respiratory acidosis is associated with an increase in potassium. Note that hyperventilation causes respiratory alkalosis, low being in the name alkalosis, and is associated with low potassium, also low calcium, and potentially low magnesium. So hypercarbia raises catecholamines and causes respiratory acidosis and increases potassium. Now some causes of low end-tidal CO2. If the CO2 drops and is low, you need to look at the waveform as well as the actual value. A sudden drop to 0 or near 0, then an absolute absence of the total waveform, you should think, where's my endotracheal tube? Maybe it came out. Maybe you're disconnected. Cardiac arrest could have occurred with no blood coming back to the lungs bringing CO2, or you can have a total obstruction to expiration. If it suddenly decreases, let's say from you're going along at 40 end-tidal CO2 and it drops to 15 during hip replacement surgery, you might think, wow, that could be a thrombus or a fat embolus. So embolization of material that blocks blood flow going to the lung, but you continue to ventilate the lung, the end-tidal CO2 drops quickly. Hypoperfusion, a drop in cardiac output, such as in a shock state. An example of this would be a patient with trauma who has a splenic injury and their abdomen is so distended from blood in their abdomen, and they emergently are brought to surgery and their blood pressure is like 70/40 and they're tachycardic. They open the abdomen, and as they open the abdomen, they no longer tamponade the bleeding and they start to bleed out. And your CO2 goes from in the 30 or 40 range suddenly down to 10 or 15, and you know that that is an extremely low cardiac output and near arrest situation. So abrupt decrease, low cardiac output could be the cause. A gradual decrease in the end-tidal CO2 is, let's say, the patient gets a little cold. They're not going to make as much carbon dioxide, and this is a decrease in metabolic rate. And if you keep the minute ventilation the same, but they're not producing as much carbon dioxide, the end-tidal CO2 is going to drop. And if you increase the minute ventilation above their needs, obviously the end-tidal CO2 will drop. So let's look at some waveforms of end-tidal CO2 and some of the diagnoses associated with them. First of all, let's look at the graphic at the far top right. And remember that the first part of the end-tidal CO2 waveform is air leaving the trachea in the dead space. The trachea doesn't have CO2 in it, and so the beginning of expiration is not at the first part of part 2 or the upstroke of the end-tidal CO2 waveform. It's before that, because that is alveolar dead space being expired. Trachea gas is being expired. Then in phase 2 you have a mix of tracheal gas and alveolar gas, and then in phase 3 you have alveolar gas, and hopefully it's uniform and homogeneous alveolar exhalation, which would then be a very flat waveform. When it's upstroking, we say, that's VQ mismatch or bronchospasm. And then the beginning of inspiration here at the end, after the end-tidal CO2 point, which is where I'm pointing to on the slide right now. That's the beginning of inspiration. So now let's look at some waveforms. Sudden loss of the end-tidal CO2 waveform. Think about, did my end-tidal CO2, was normal at 40, now it's near 0. Maybe the end of the tracheal tube got disconnected or dislodged or kinked or obstructed, or maybe there's no cardiac output, and those could be the causes of sudden loss of that waveform. A decreasing end-tidal CO2, you could have a tube cuff length, and you could be taking in air around it instead of only the exhaled gases, air from the hypopharynx, and that air from the hypopharynx has very little CO2 in it, if at all, and so it's going to decrease the amount of CO2 returning. And you blow up the cuff to the tube, create a closed system, and suddenly your CO2 is back to normal. CPR, when you're doing CPR, the higher the CO2, in general, the more effective you say your compressions are. And you attempt to maintain it, hopefully more than 10, and more than 15 would be great if you're doing great compressions and moving blood around. A sudden increase in end-tidal CO2 during CPR is often return of spontaneous circulation. Bronchospasm, we look at that upstroking of phase 2, upsloping of phase 2, hypoventilation, a high number end-tidal CO2, hyperventilation, a low number end-tidal CO2, and then at the very bottom, problems with the inspiratory or expiratory valve can give us a situation of rebreathing, which by definition is an elevation in baseline end-tidal CO2. That is, inspired CO2, which should be 0, is something greater than 0. And in the first graphic, it's showing an exhausted CO2 absorbent or an incompetent expiratory valve in which the baseline's above 0, but the pattern stays very square, as opposed to an incompetent inspiratory valve where the baseline is above 0, but during inspiration, when you have that incompetent inspiratory valve, there is some CO2 in the circuit that comes into the patient, and it's downsloping, not sharply, but slopes off at an angle and changes that pattern of phase of inspiration. The next key word is pulmonary physiology or shunt. Shunt is a situation where ventilation over perfusion is less than 1. That is, perfusion without ventilation occurring. An example would be an endobronchial intubation. Let's say you put your tube down to 27 or 28 depth. You didn't realize it, and it's out the right main stem. The right lung is being ventilated. The left lung is not being ventilated. The left lung's still getting blood, so that is a shunt. And one of the classic ways for this to happen is an obese patient undergoing robotic surgery or laparoscopic surgery. You put them in a head-down position. The abdominal contents move up towards the lung, push the diaphragm up, and the tube slides down a bit, and suddenly your peak airway goes up, pressure, your saturation drops, and you have a situation where you have an endobronchial intubation. So endobronchial intubation decreases saturation because only one lung's being ventilated. It increases the AA difference, that's shunt. Initially, you'll see a drop in end-tidal CO2 because you're delivering the full minute ventilation to only one lung. And hypoxic pulmonary vasoconstriction in the lung that's not being ventilated is going to increase pulmonary vascular resistance overall. The normal anatomic shunt is only about 3% of the cardiac output through the bronchial, pleural, and Thebesian veins. And if you have a shunt situation, you go, I want to increase their PaO2, and you start increasing their FiO2, and it's not improving their oxygenation, then you can say, aha, that's probably a shunt situation where FiO2 increases do not improve oxygenation. A shunt can be expressed by the AA difference and by venous admixture or shunt equation, which is shown here. Shunt over total flow is equal to the difference in content of end pulmonary capillary blood minus arterial blood over end pulmonary capillary blood minus venous content blood. And this shunt equation should give you a number less than 5%. When it's greater than that, we say it's a shunt situation. The next keyword is pulmonary physiology dead space. And this is where ventilation over perfusion is greater than 1. That is, ventilation is occurring without perfusion, and zone 1 of the lung is an example of that. At the top right shows the zones of the lung. In zone 1, P big A is greater than P little a is greater than PV. Since alveolar pressure is greater than arterial pressure, there's constriction of the blood vessels, and we say that the top of the lung in the upright position is ventilated without much perfusion. V over Q greater than 1. And the normal dead space of the lung is about 2 mils per kilogram, or approximately 150 mils. This includes anatomic and alveolar components. This dead space is really the plumbing to get air down to the gas exchanging parts of your lungs. So this is the trachea down to the terminal bronchioles, and the ratio of dead space to tidal volume. If it's 150 mils of dead space and your tidal volume, let's say, was 450 mils, a normal tidal volume, the ratio then would be 150 over 450, or 1/3, and that's normal. About 1/3 of every breath goes to dead space. And it can be approximated by the Bohr equation, which uses arterial CO2 and expired CO2 collected from a patient to try to calculate this VD over VT, which again is normally about 1/3 of every breath. By doing a tracheostomy in a patient, you reduce the dead space to tidal volume, and the reason being that you're reducing dead space is because you're basically removing the hypopharyngeal area, and a tracheostomy VD over VT decreases from about 1/3 down to about 0.15. Now, if you intubate someone, put an endotracheal tube down and leave them spontaneously breathing, it actually decreases dead space. Why? Because the endotracheal tube inside diameter and the volume of it's smaller than the hypopharynx. And when you intubate someone and don't start mechanical ventilation, we can say, aha, that's reducing dead space. But if you intubate someone, reduce their dead space, and then start breathing for them with positive pressure breathing increases P big A, which is alveolar pressure, which creates more zone in 1 of the lung, which actually then, even though that endotracheal tube went down, now that you're mechanically ventilating them, dead space goes up to about 0.5, which is 50% of every breath. Put a face mask on someone, and that adds even more dead space. Usually, if you're up in the intensive care unit and you calculated dead space in a patient, it was greater than 0.6, you will not be able to wean them because there's so much dead space, they are not ventilating adequately. Factors that increase the ratio of VD over VT: high airway pressure, erect posture, the elderly, and things like pulmonary embolization and mechanical ventilation because of positive pressure ventilation. Where is dead space in the circle system? It is distal to the Y piece. And if you add extracorrugated tubing, assuming that you have a normal inspiratory and expiratory valve, this does not add dead space. So if the patient's head away and you have extracorrugated tubing stretched out, dead space still remains just distal to the Y piece, assuming that you have a normal inspiratory and expiratory valves functioning. Now, if you put a humidivent between the Y piece and the patient, that is adding dead space. And I've actually had pediatric cases, neonatal cases, where I had to remove the humidivent because it added enough dead space that I could not keep the carbon dioxide down in the patient. The last key word in this part 2 is pulmonary physiology, lung compliance. Lung compliance is a change in volume over a change in pressure mathematically. So what this is saying is if you blow up a lung with large volume and the pressure isn't very high, that's a very compliant lung. If it doesn't take much pressure to blow up that lung. The total compliance of the system includes the thoracic cage as well as the lung itself, and we actually add those in parallel rather than in series. The thoracic cage compliance is normally about 200 mils of oxygen for each centimeter of water. The lung compliance is usually about 200 mils per centimeter of water pressure. And then when we add in parallel, we do 1 over the total compliance, then becomes about 100 mils of gas for each centimeter of water, total compliance of the pulmonary system. Now, there's different types of compliance, dynamic compliance and static compliance, but let's first look at the pressure graphic curve over on the top right, showing peak compliance, or peak pressure that is, and plateau pressure. And as the air goes in, there's a peak pressure generated, and then as the pressure that's necessary to keep the lungs open at end inspiration, when gas flow is no longer present, that's called the plateau pressure. And we use peak and plateau pressure in our calculations of dynamic and static compliance. So let's look at dynamic compliance first, where a change in volume is the tidal volume over a pressure, which is, we use the peak pressure on the bottom minus any PEEP if we have any. And that dynamic compliance reflects the resistance to gas flow present in the ventilator tubing, in our endotracheal tube, in our airways. And so if the peak pressure goes up, we often think, well, is something obstructing my endotracheal tube, or is this patient having bronchospasm? And if peak pressure goes up, you can see how it affects dynamic compliance. And so if dynamic compliance is reduced, we say, aha, maybe it's an obstructed endotracheal tube or bronchospasm. As opposed to static compliance, which the volume is tidal volume, but we use plateau pressure on the denominator, minus PEEP if there is PEEP. And it's a measure of the airway pressure required to hold the lungs and chest wall at end inspiration when gas flow is absent, and really is reflecting what's going on in the lung. So if the lungs are stiff, if there's pneumonia, this static compliance will be decreased. So I like to think of dynamic compliance as getting the air down to the lungs and things that affect it, like a plugged endotracheal tube, a constricted endotracheal tube, bronchospasm, affecting dynamic compliance, while a stiff lung has to do with static compliance. And this ends part 2 of a 5-part high-yield keyword review on respiratory and thoracic topics, and I hope you have a great day.